I feel like these 4 scenarios in my mind are a no-brainer.
Let me push you a little on that because one of the things we often think about when we see new data sets is how do we apply this to our patient population?
Yes.
So are there factors that would push you to use a T-DXd Pertuzumab approach in the first line or factors that would push you not to use this combination in the first line?
Yeah, I mean, certain factors that would definitely push me to use it would be like, okay, a short recurrence from their, adjuvant treatments, where they received an HP-based approach, if you will, or they received chemotherapy and they still have recurrences. I think you want to reach out to an antibody-drug conjugate, an impressive one at that, where you've seen wonderful waterfall plots and wonderful progression-free survivals. So I would definitely want to consider for that. Another thing that we have learned also in HER2-positive disease is a third of HER2-positive disease also harbor the PIK3CA mutations. And when we have looked at analyses by PIK3CA mutations with Cleopatra, we've seen that those patients do poorly. It is an independent poor prognostic factor. And that was one of the stratification factors actually in the DB09 study as well. And there we did not see a difference in benefit, regardless of having the mutation or not. Yes. We've seen similar kind of analyses even with DB04 in HER2-low breast cancers where PIK3CA mutation status did not matter. So I feel like if I know upfront for a patient that there is a PIK3CA mutation, there also I feel like I really want to give T-DXd over THP where I might potentially lose that benefit. And the third one, I feel like it's rarer in HER2 positive to see brain metastases really upfront in the first or second line, but it's still seen, it's still present. In fact, when we think about even the Catherine data, where we utilize TDM1 in the early stage residual disease setting, the first site of recurrence that we think about had CNS recurrences as well. So it is still something that we see in our patients. And we have such robust data from Destiny Breast 12 in treatment of brain metastases as well. And so I feel like those 3, I feel like, are definitively a way to think about, I should definitely offer T-DXd to these patients. Outside of that, like a lot of disease burden, a lot of, visceral disease burden, or just tumor burden in general. I feel like because it works so quickly, because it works so effectively, I feel like I want to reach out to something where I can actually control the pace of the disease with a very efficacious drug. So I feel like these 4 scenarios in my mind are a no-brainer to think about, yes, I definitely want to try T-DXd, given the totality of the data that we have with this molecule.